Also, I'm a translational investigator where I bring science close to the bedside, where we develop patient-derived animal models and study the different options to personalize the treatment of cancer in general and specifically kidney cancer. And my focus has been in GU oncology, and my focus have been to develop less toxic treatments for cancer and to develop new biomarkers for cancer and kidney cancer.
Thank you. Well, I think we've got everyone who's joined us. We're ready to get started.
Thank you for inviting me today in this first virtual symposium for the Judy Nicholson Foundation. My task today is to review progress in immunotherapy, specifically for clear cell kidney cancer. I will discuss the other cancers, types of kidney cancer briefly, but this would be the emphasis. My aims today is to review the different treatment options as far as immunotherapy for kidney cancer, where it is indicated, where it is used, discuss the toxicities of these treatments, discuss where this is currently approved as a treatment option, and furthermore, discuss the clinical trials that are being done today and where the direction of future discovery would be. Let me start. Metastatic kidney cancer is treatable. Early kidney cancer is curable. What I'm saying is that stage 1 and stage 2 kidney cancer is very often curable, and that can be treated primarily with partial or radical nephrectomy. Very often in this day and age, we try to do partial nephrectomy to spare the kidney. This is the only slide for adjuvant treatment for me today. The adjuvant options for kidney cancer are not because of no trials, it's because of unsuccessful trials in this setting. The only drug that has been approved today is sunitinib, based on the S-TRACK trial, which was given in high-risk RCC, and sunitinib was given for a year compared to placebo. There was significant improvement in progression-free survival of these patients, however, had significant toxicity, which include cardiovascular toxicities such as hypertension, GI toxicities such as diarrhea and colitis, and significant hand-foot syndrome, hypothyroidism, cytopenias in patients. So in the setting of stage 3 RCC, sunitinib is certainly an option, but it's important for the patient and the clinician to make that decision together. The incidence of metastatic kidney cancer is not of positive note. I can tell you that despite 400,000 cases of global kidney cancer globally, there are 175,000 deaths from kidney cancer. And in this country, 15,000 of those patients would succumb to kidney cancer. The good news is that if kidney cancer is localized, you can still cure those patients. To delve into statistics and the importance of this, you will realize later, is that out of 100 patients with metastatic disease, only 8 patients or persons will be alive after 5 years. So there is a need, there is a gap, and it is important to develop new therapies for metastatic renal cancer. When kidney cancer spread, where does it commonly go? It goes to the lungs, it goes to the bones, and other areas, including the liver, brain, ovaries, testicles, and many more, very frequently in the lymph nodes. It is encouraging to say that metastatic RCC is not the same in every single patient. And it is the most important slide that I want us all to know. It's the International Metastatic RCC Data Consortium. And these are what we call prognostic criteria that are important as far as outcome for patients with metastatic renal cell cancer. These 6 prognostic factors are important to determine at the initial point of the diagnosis of the metastatic kidney cancer. 0 is the point that you give for those who do not have this condition present. 1 would be if it's present. And the higher the score, the higher or the poorer the outcome will be. And you will realize that in the next few slides. So poor prognostic factor based on the IDMC criteria include presence of systemic disease less than 1 year after nephrectomy. If you have that, that's 1 point. Performance status of less than 80% Karnofsky score, what in layman's term would mean that you're in a chair 50% of the time, not able to function, not able to ambulate. But if you have more than 50% of activity and you're able to do activities of daily living with minimal effort, you have a good performance status. Other prognostic markers include hemoglobin of less than 12, which means anemia, calcium of less than 10.3, neutrophils of greater than 7 times 10 to the 9th, platelet counts of more than 400,000. Those are poor prognostic markers. And based on that, we can stratify those patients based on their numbers. If you have none of those prognostic markers, you have an average survival, even with metastatic disease, of 35.3 months, with intermediate risk, which means you have 1 to 2 factors, that's 16.6 months. And for those with 3 to 6 poor prognostic factor, the survival is 5.4 months. So the message is that patients with metastatic renal cancer do not have the same prognosis. Based on the different treatment options that we have for metastatic kidney cancer, we have 3 general targets. The first target for the treatment of metastatic cancer would include the vascular endothelial factor or growth factor known as VEGF. The second is the immune system, which is immunotherapy. The third is what we call escape pathway, and one of the more prominent targeted treatments that we have is the escape pathway known as mTOR. So in summary, we have VEGF, immunotherapy, and mTOR. There are other targets, however, these are the clinically relevant treatment options today. To explain and elaborate further, as far as the vascular endothelial growth factor, we have here a blood vessel, and we have the cancer cell attaching to the blood vessel. The green are the what we call malignant proliferative cell. And if you go to B, the green cells actually produce these yellow pellets, and these yellow pellets actually try to attach on the blood vessels. And with time and with more nutrition, the green cancer cell is able to produce blood vessels or new blood vessels, allowing the cancer to penetrate the blood vessel. And after it penetrates the blood vessel, will be a focus of spread of the cancer cell to other parts of the body. In principle, that is how the vascular endothelial growth factors enhance the ability of the cancer cell to spread. That's why we have multiple oral agents or targeted drugs that have been developed to stop or slow down this process, which include several of the VEGF inhibitors, such as sunitinib, pazopanib, axitinib, lenvatinib, sorafenib, and many more. The other way of looking at this whole picture is looking at the tumor microenvironment. Here you have the blood vessels. Here you have the tumor microenvironment. And the microenvironment includes the nucleus of the cancer cell. And you can see here mTOR, AKT, PI3 kinase, which actually allows, if unhindered, proliferation, cell survival, and angiogenesis of the kidney cancer. However, you can block that nowadays with drugs like everolimus or temsirolimus to prevent growth of the cancer cell. The other aspect is the immune microenvironment. Normally, when a cancer cell goes into the human body, circulates around the human body, there are what we call cells that are activated, such as known as T cell and antigen presenting cell. However, like any negotiations, they actually, I simplify this, they actually have good cordial relationship between the cancer cell and the body. And normally, because they have a good handshake, that relationship is good. And the body's T cell is not able to recognize the renal cancer cell as foreign. So they have a cordial handshake. However, that's not good because that allows the cancer cell to grow. Now, one of the strategies to allow the immune system to work maximally is to break off that handshake. And by doing that, we have drugs known as PD-1 inhibitors, programmed cell death inhibitors, or programmed cell death ligand inhibitors, PD-1 and PD-L1 inhibitors. What that means is that these agents are what we call agents that remove the brake of the normal immune process. And by doing that, we normally prevent inhibition of the detection of the cancer cell. By blocking that, now we allow the T cells and the antigen presenting cells now to be activated. And specifically, we have a drug known as CTLA-4 inhibitor known as ipilimumab, and we have PD-1 inhibitor known as nivolumab, PD-L1 inhibitors known as atezolizumab, which maximally puts off the brake of the immune system, allowing our immune system, which is inherently present in our body, to be maximized and optimized to kill those tumor cells. So this is just simplistically trying to illustrate that there's that handshake between the antigen and T receptor, so there's no detection, and then we have the PD-1 and the PD-L1 inhibitors. Based on that background, we now can delve in to the different clinical trials and the reason why we use the different drugs for treatment of metastatic clear cell renal cancer. The combination of ipilimumab and nivolumab have been in the forefront of this study. It's combination of a CTLA-4 inhibitor and a PD-1 inhibitor, and this included 1,100 patients enrolled in this clinical trial. This was a sunitinib, nivolumab, ipilimumab trial, 550 patients on the double immunotherapy drug, and another group on the sunitinib, which is standard of care. And now you realize the importance of classification based on the criteria. They were intermediate or poor risk patients. Interestingly, after a follow-up of 25 months, we see a clear improvement of 15% in the overall survival of these patients, 75% compared to 60%. We do see a significant improvement in objective response, shrinkage of the tumor, 42% compared to 27%, and complete response, which is as good as cure, 9% in the combination arm compared to 1%. That's not a lot, but that's the beginning. The combination arm did show that it had toxicity. However, the combination immunotherapy was not more toxic than the oral agent sunitinib, which is good. But of note, I am not saying that immunotherapy is benign. I'm saying it has toxicity and has to be given in the context of supervision and monitoring by your oncologist. The discontinuation rate with the combination immunotherapy was 22%, and with the oral agent, it was 12%. What I just said in summary is that 75% of all patients with metastatic kidney cancer, intermediate or poor risk, have a significant improvement in their survival compared to a VEGF oral inhibitors. It is a matter of being alive or not. Based on this preliminary data and interesting data on immunotherapy and the effectiveness of anti-angiogenic drugs, the vascular endothelial growth factor drugs, VEGF, several clinical trials were done, and the combination of axitinib and pembrolizumab, axitinib and abulimab, levantinib and pembrolizumab, which are anti-VEGF plus PD-1 inhibitors and PD-L1 inhibitors, they have shown on preliminary studies to have a response rate of 58 to 73%. Realizing that majority of the anti-VEGF drug would produce only an objective response of between 30% or so. Combination immunotherapy was 50%. Now we're seeing responses of higher than that. So based on these trials, combination treatments compared to standard of care was done in the Keynote 426, which was a randomized open label trial, first line for metastatic renal cell cancer. They were treated with combination drug pembrolizumab and axitinib, VEGF inhibitor plus a PD-1 inhibitor compared to sunitinib, oral drug. And this was continued for 24 months for the pembrolizumab, and patients were treated as long as they were responsive to the drugs. Very interesting results. What we see is that there was a significant improvement in progression-free survival, and median progression-free survival was improved by 4 months, 15 months compared to 11 months in those who were receiving pembrolizumab and axitinib. Of note is that an interim analysis of this, patients were continuing to respond to this combination. In addition to that, abilimab and axitinib was compared to sunitinib in a separate trial, and patients were randomized to either of the arms. And what we will see, which I will summarize in a few minutes, the results. The toxicity was significant. It was about 20%, however, quite manageable for most of the patients on the combination arm. And of note, the liver toxicity was significant, resulting in discontinuation of the combination drugs in 13% of the time. This is where we need to look further. What we have shown here in A is the patients who have PD-1 expression on their slides and the overall population. Not to confuse you, I'll just concentrate on the overall population. No special staining, everybody with kidney cancer with metastasis, regardless whether they're good risk, intermediate, or poor risk, treated with avelumab and axitinib compared to sunitinib. What we have shown here is indeed very good. There is a median progression-free survival improvement of at least 4 months. And that is quite encouraging in that we are further able to improve our treatment options today. Just looking further and trying to analyze further all these options, and we can clearly see that compared to the double agent and sunitinib, there is an increase in the complete response rate, cure rate, partial response, and the presence of stable disease. Of note is that only 11% of those patients who were on the combination arm of abilimab and axitinib have progression of the disease. The rest responded. With sunitinib, it was 21.7%. This is a long laundry list of side effects of the combination arm and single agent arm. I will not belabor you with this, just emphasizing that the combination arm obviously have more toxicity as far as diarrhea, hypertension, hand-foot syndrome, uh, as far as grade 3, and hypothyroidism. But if you are able to manage this toxicity, you get a better improvement in response and also prolongation of your survival. I like to summarize things and simplify things for you. What I have discussed so far is with single agent VEGF inhibitors. I put it down here: response, complete response, progression-free survival, and overall survival. This is the comparator, so we don't have hazard ratio here. You can see an improvement in the survival overall response of 30%, complete response of 1% to 8%, and majority of those patients don't progress on oral VEGF inhibitors 8 to 11 months. However, if you combine two immunotherapies, ipilimumab and nivolumab, the response rate increases to 42%. The complete response again increases 9 to 11%, and the progression-free survival increases to 11.6% with a hazard ratio improvement of 63%. Majority of the clinical trials in different cancer would just show a hazard ratio of 0.7 or higher. If you combine a VEGF inhibitor and an immunotherapy, overall response rate increases to about 60%. Less toxic, hopefully, two different mechanisms of action. However, the complete response rate is lesser. You will note here that the progression-free survival again have significantly improved. So we can say safely that we have improved the progression-free survival from 8 months to 15 months, which can translate into many years of survival for the patients with metastatic renal cancer. This is the NCCN guidelines last year, 2019. Any prognostic group, the option would be these drugs. And for intermediate and poor risk, there's no question that these are the options, but the best option would be the combination immunotherapy, ipilimumab and nivolumab. I will move a little faster because this is the 2020 guideline for today. Good risk renal cancer. Now we have the option of treating them with pembrolizumab and axitinib, although we do not have the overall survival long-term follow-up, and abilimab with axitinib in conjunction with sunitinib or pazopanib. In the intermediate risk patients, again, we have these options. For the poor risk patients, again, we have the ipilimumab, nivolumab. However, of note, you can use the combination VEGF immunotherapy drugs here. So a plethora of options is good because now the oncologist who's treating you can choose depending on your tolerability and your toxicity profile. There are new agents that are being studied. There are several of those which target IL-10, other immunogenic factors such as LAG3, other immunotherapy drugs such as IL-2. We have new IL-2 drugs such as NKTR-214 in combination with a PD-1 inhibitor, so that certainly is interesting. We have adenosine inhibitors. We have the glutamate inhibition, which is very important. And of note, we have very early studies, and we at Mayo Clinic will be doing our first in-human study of SSI4, which is a SCD1 inhibitor, which is a fat inhibitor. And we have shown in preclinical studies that it causes significant inhibition of many renal cell, clear cell lines, and will be hopefully starting its first in human study that we developed the drug at Mayo Clinic. There are certainly other studies that are ongoing for non-clear cell. I promised to talk about non-clear cell. So there's the salvolinib versus sunitinib, lung cancer drugs, crizotinib, compared with cabozantinib, sunitinib. So these are drugs that are specifically targeted for non-clear cell RCC, and there are furthermore other studies which are looking at combination ipilimumab, nivolumab in this setting, and combination of atezolizumab and bevacizumab, VEGF inhibitors, and PD-1. So there are tons of new studies that are being done today. I hope I have achieved my goals today to enlighten you on the treatment options for metastatic clear cell RCC, discuss the importance of the IDMC criteria, emphasizing that not all metastatic renal cancer are the same, and reviewed the different clinical trial and basis of the recommendations for treatment for metastatic kidney cancer, depending on good risk, intermediate, and poor risk, and at the same time, review the ongoing clinical trials that are being done today, and review also the options for patients with non-clear cell morphology. Thank you, and I would be glad to answer your questions.
Thank you so much, Dr. Tan. So would it be, we have some people asking if it would be okay if we shared your slideshow presentation on our website. Would that be all right?
Sure, as long as they don't sell it on the internet.
Okay, great. And also, Deb Maskins had a question. She said 8% 5-year survival for stage 4 is a pretty frightening statistic. How recent is it? And what do you personally think the 5-year survival is now with newer therapies, including immunotherapy?
I think it's a lot higher. That needs to be updated. That was in 2018. However, those are general statistics that are published by the American Cancer Society. And I think my gut feeling right now is the average survival of treated patients with metastatic clear cell RCC is 2 years or more. So that 5 years is no longer 8%, it could be 20 to 30%.
And Michelle Pollard has a question. If you start with Cabo, can you go back to IP and Nivo?
Yes, you can.
I'm going to unmute the microphones if anybody wants to ask a question, or you can type it into the chat box here at the bottom. Another question, are there any treatments which would prevent going back to immunotherapy?
Certainly, there are baseline toxicities that are present in the patients that would prevent them from getting treatments, such as prior immune type of diseases like autoimmune disease, presence of significant GI colitis, presence of refractory hypertension or cardiovascular morbidities. Those are just to mention a few of the contraindications of going back or going to those treatments.
Do we have any questions?
I hope I did answer those questions.
Where can we find the Mayo Clinic clinical trial requirements?
On the Mayo Clinic clinical trial website. The SSI-4 is not yet open. We have to apply through the FDA regarding that trial. So we have the preclinical data published since 2017 or 18, but the clinical trial is not yet on our website.
I'd like to take this time to let everybody know that we're going to be having one of these conversations every Wednesday throughout the month of June. So if you haven't already, you can sign up for next week's speaker. Jayla Barnes will be talking about the specific role that kidneys have in the body. And then we have other discussions coming up later in the month that I think you'll find very interesting too. We'll be sending out information on that in our newsletter and our website and social media, so please stay tuned. We've got another question here. About 1 year ago, this person was diagnosed with early stage 3 and had their kidney removed. So far, the follow-up CAT scans have revealed that there has been no spreading. There were no clinical trials available to this person at that time, and was wondering your thoughts about pursuing immunotherapy at this time.
Without the presence of metastasis at this time, I would not encourage off-trial treatment with immunotherapy. If there is a clinical trial that allows them to participate on an immunotherapy. However, most of those trials would be randomized placebo control. So the person has to be willing to be in a placebo arm if that's what they intend to do.
And are there any biomarkers for individual immunotherapy regimen?
So right now, we wish we have biomarkers. There are biomarkers that have been studied. However, none of them are ready for prime time that can be used clinically to predict response. PD-1, PD-L1, CA9 have been used as markers, but these markers at this point do not predict better prognosis. There might be some inkling towards PD-1, PD-L1 responding better to the PD-1, PD-L1 inhibitors, but that's not a requirement for getting started on treatment on PD-1 or PD-L1 inhibitors.
How do you feel about the combination use of radiation and immunotherapy?
I think that's an interesting area that needs further study. We certainly know that the immune system and combination with radiation has a lot of opportunity that we need to explore.
And can you address MK6482 or pazopanib in phase 3 trials?
So pazopanib is an approved standard drug for good risk metastatic clear cell RCC and can be an option for non-clear RCC patients.
Are there any agents that can be added to improve lymphocyte infiltration in microenvironment?
There are studies that are looking into that, and it's important to community. We actually at Mayo Clinic have an immune-based therapy looking at a novel agent which targets CD45 plus pembrolizumab in a phase one clinical trial known as TJ 11333. So it's an open trial for those who have progressed after standard treatment for metastatic renal cancer. It's not for just metastatic renal cancer, it's for all comers, but they have to be refractory and have to progress on standard treatment for their cancer. And it's open for patients.
Michelle Pollard would like to know, why haven't they studied immunotherapy plus pills directly against nivolumab and ipilimumab? Seems as though these are presented as treatment options which present similar outcomes for immediate and poor risk, but they haven't been studied together.
So it's just a matter of time. I think they will study those, and of course, the importance of toxicity profile, non-competing toxicity or different toxicity profile in planning further clinical trials.
Okay. Well, we're winding down on the questions here. Does anyone else have any questions before we let Dr. Tan get back to research? So this video is going to be, I'm going to trim off the beginning of it because I had a little bit of dead air at the beginning, and I'll have it uploaded to our website and social media by tomorrow. So if there's anyone who missed a piece of this or would like to share it with somebody, feel free to check back on our website and our Facebook or Twitter page to find that. And please, thank you for joining us, and thank you for signing up for the coming conversations. Most of all, Dr. Tan, everyone in the chat is thanking you right now for coming and sharing this discussion with us and answering our questions. So thank you very much for being with us.
Thank you, everyone.
All right, everybody. Well, then until next week, thank you for joining us for Kidney Cancer Conversations. I'm Scott, and I look forward to seeing everybody next week. Have a great day and stay safe out there.